Good afternoon, everybody. This week we're going to try something a little different. Instead of the typical you come to class and listen, stand up, or watch me up at the front of the classroom do a whole lot of different and exciting things, we're going to go ahead and I've posted the lecture for Introduction to Trauma, Soft Tissue Injuries, and Burns up online. And just see if this works. I've tried it in the past. I've had success sometimes, not success others. So we'll see how you guys do. And we'll kind of go from there. So, when we talk about trauma, I think one of the things we need to understand is the group of people that trauma affects is not the same group of people that most of the other illnesses we've talked about thus far in class affected. If we look at heart attacks, strokes, even kidney failure, things like that, we're usually talking about an older population. Unfortunately, trauma typically affects a population really about the age of this class. So for me, this is kind of an important thing. I often hear EMTs run around and they'll talk a lot about how, oh, they love trauma. But I think sometimes when they do that, they're not really thinking about the whole situation and what that actually means to the families and to the people that we're talking about. That this is a life-changing event, and I think everybody needs to kind of understand that when we talk about trauma, it is kind of a big deal with respect to whom it involves. So it's important to understand that trauma is the leading cause of death from persons 1 to 44. Again, as I just said, we've talked about diseases and illness in this class thus far that typically affect older people. This is the group of people in our country that actually make a difference. This is the majority of the workforce is between 20 and 45 or 20 and 50, and so we understand a little bit about trauma and kind of what it means, but we're going to go into a little more depth with that and talk a little bit about what's going on as far as trauma care in the 21st century. We'll talk a little bit about the financial impact on the country, lost hours, cost of the care itself, and then we'll talk a little more about just the incident, the pre-incident, the incident, and the post-incident. So, in this century, we know a couple things. First off, EMTs can make a pretty big difference in patients' life through good trauma management. These lead to lengthened lifespans, and the financial liabilities can be decreased pretty significantly. If we look at trauma, this is one of those things that we need to understand. Most of you in this class will be affected by it at some point. This is the probable versus the possible. If we look at probable, everyone in the classroom at some point in your lifetime will be involved in a car accident. Statistically, some of you more than one. I think the actual statistic is about 1.2 accidents per person per lifetime. So some of you, about 20%, will actually be involved in more than one accident. Um, when that happens, or maybe not, I mean, not necessarily in a car accident, but about 60 million injuries in this country per year. Probably that's way underreported, but that's how many people go to the hospital. And of that, 9 million are disabling. This is a pretty big deal in our society. And we need to understand that as EMTs and how we fit into that trauma care. So the financial burden of trauma patients is can't be underestimated in any fashion. We know that about 40% of the United States healthcare budget is based on trauma. In addition, about $300 billion in lost wages, insurance costs, property damage, and employer costs are accrued specifically because of trauma. This is a big deal. Even if we ignore the patient in this whole thing, when we talk about trauma and trauma care and what it means, it's definitely kind of a big deal as far as what it's doing to our country and how it burdens our country. So the cost of trauma care per year, if we break this down a little bit more and compare it to some of the things that we've talked about before, we've talked quite a bit about cardiovascular disease in this class. We haven't talked a whole lot about cancer. We don't really do a whole lot with that, pre-hospitally. But we also, if we compare just cardiovascular care with trauma on this little graph, we can see just the tremendous burden and cost that trauma costs our nation per year in comparison to cardiovascular disease. So we find that cardiovascular disease is about 55 to 60 million dollars a year. Trauma is someplace between 300, or sorry, not million, billion dollars a year, and trauma is about 300 to 325 billion dollars per year that it influences the country. More importantly, if we take and we look at a lost time from an average length of life, if we assume that most people live to between 75 and 80 years old, we see that trauma affects the group of people that are really in the prime of their life. That people affected by trauma who die in trauma are actually the younger portion of the population, and on average are losing about 35 years off their lifespan. If we look at cardiovascular disease, about 10 years, and then cancer, someplace between 15 and 20 years. So this is a big deal. These are young, healthy people that are dying in these accidents, and we need to understand that when we care for these people, it is a very different population than what we are dealing with when we talk about, again, cardiovascular disease, stroke, those kind of things. So when we talk about trauma, we can talk about the pre-event, the event, and the post-event phases of an accident. In the pre-event phase, we talk a lot about, and you guys will be as you move on into your career, a part of safety and public education. You guys will probably be in charge of seatbelt classes and child seat classes and telling people about wearing helmets and all these neat things. That's a part of your job. Um, as far as violence and unintentional trauma, there are more deaths from this than all other diseases combined, and then violence actually provides for 1/3 of these deaths. So if we can knock some of these things down, we can actually save a lot of lives, a lot more. A little action in this case provides a lot bigger response than we see in a lot of other illnesses. So you as providers will be a lot of kind of putting this out there. If we look at trauma deaths and how they break down, we see that most trauma is unintentional. However, we also see a huge piece of the pie is combined between homicide and suicide. And that's actually kind of a frightening point, that violence is a pretty big chunk of this entire thing. Many deaths from suicide especially are preventable, and many deaths from homicide are also preventable. So again, as providers, it will be kind of your responsibility to kind of push that message out of how do we help to prevent these issues. If we break down unintentional trauma just a little bit further, we find that firearms are actually a huge chunk. One of the frightening things is we really don't actually know the statistics on this. The Congress a few years back actually pulled the money from the Centers from Disease Control to actually study firearms death as a disease. So no one really knows exactly how many. Well, we do know that it's probably about 25% of all unintentional trauma is caused by firearms. And that's pretty frightening considering we always think about motor vehicles, which are the biggest share, but unfortunately firearms are pulling up a close second onto that game. So during the event, what we hope we're doing is we're practicing what we preach. So if we tell people to wear a seatbelt, hopefully we're wearing a seatbelt. If we tell people to wear a helmet, hopefully we're wearing a helmet. Hopefully, if we own firearms, if we do whatever, we maintain them, we keep them in a safe, we keep the triggers locked, all those neat things. But we want to practice what we're preaching as far as maintain, keeping people safe. We want to keep ourselves safe as well and our families. So the post-incident phase, this is after the actual incident, after the trauma incident. There's something called the trimodal categorization of trauma deaths, and this is split into three phases. So in the first phase, most of these deaths are completely unavoidable. No care you give, no care anybody gives is going to save this person. About half the people who die in trauma die within the first minutes, and nothing anybody's going to do is going to fix that. In the second phase, a lot of times it can be prevented by good hospital and pre-hospital care. That's about 30%. And then in the third phase, weeks later, up to 2 to 5 weeks later, about 20% of patients, these patients die from injuries that probably were unavoidable. However, they managed to survive to another phase. Maybe they developed um, a post-operative infection, became septic, pneumonia, all these type things that can happen after the fact when we talk about trauma. So one of the most important things that we talk about in EMS is this concept of the golden hour. Now, the golden hour is based on real life studies, and what it means is that we have about 1 hour from the time of the incident till our patient gets to the operating room. Now, the important kick on this is that it has to be our patient getting to the operating room. If we fail that piece and we just say, okay, get him to the hospital, we may fail on this, and that's a pretty important point. We want to make sure that we take our patient to the appropriate facility that can actually manage trauma patients. Oftentimes, if we take them to the closest hospital, we find that's not necessarily the best solution. So let's break down the golden hour a little bit. So you guys haven't run very many calls, but a good response time from the time the call received till you get to the scene, some of the best services in the country, it's usually between 8 and 10 minutes. Really, and that's in an urban environment where we have lots of stations and we don't have, 20 and 30 miles like we might see between a station and a call up here. It's still about 8 to 10 minutes. From the scene to the hospital, again in an urban environment, about 8 to 10 minutes. And what we shoot for is time on scene of less than 10 minutes. Because remember, it's the time to the blade, to the surgeon's blade in the hospital, not just the hospital. These patients need to go to surgery, not just to the hospital. So this is why they need to go to trauma centers, because this happens very quickly. So trauma centers are hospitals that are specialized in trauma. They have an emergency room where there's a surgeon on call, or in the hospital, if we talk about level one trauma centers, someplace like Denver Health, and they're ready to operate just as soon as the patient arrives to the hospitals. Unfortunately, hospitals, just if we take it to the closest facility and they don't have this, we start to see some problems with it. So if we look at this time to blade from the arrival at the emergency room, if we go to the closest hospital and just say, okay, I'm going to go to the closest hospital, we find that the typical patient, when they arrive there, takes nearly 100 minutes from the time they go from the emergency room to the time they hit the operating room. This is kind of a dangerous thing, because now we've blown clear through the golden hour. Even if we were only 20 or 30 minutes on scene, we've now completely trashed this. If we go to a trauma center, however, we're usually less than 30 minutes up to the operating room, and now we're right in that golden hour period, and our patient is going to get the best care that's possible.